you can start now.
Thank you so much. Good evening, everyone. Assalamu alaikum. This is Ahmed Az. I'm the regional franchise head for Newbridge Pharmaceuticals in the MENA region. It's a pleasure welcoming you all, and thank you so much for your attendance to this scientific symposium. And it's our pleasure to welcome you to this symposium, and looking forward for a very rich scientific one and enriched with our faculty speakers. Before we start, I'd like to introduce Newbridge Pharmaceuticals to you, to just let you know from our first experience in engaging with you, who we are and what we are doing in the medical devices domain. So Newbridge, in brief, is a specialty pharmaceutical company focusing on the in-licensing and commercialization of US FDA and European approved innovative products that address unmet needs in the MENA region. Newbridge is operating since 2010 across the Middle East and North Africa region, with our headquarters in Dubai and satellite offices in Saudi, Egypt, Lebanon, and Morocco. We are covering the Middle East, North Africa region. Newbridge, in brief, provides a one-stop solution for our partners, multinational pharmaceutical companies and medical devices companies across the globe, to be representing them over different types of representation. We represent them to the regulatory and government affairs responsibilities, medical affairs and pharmacovigilance, sales and marketing as well, logistical solutions, through a compliant framework where we operate through. Newbridge has a diversified therapeutic focus over oncology, hematology, neurosciences, rare diseases, immunology, metabolic and GI diseases, and also medical devices, for which we are hosting this event. Newbridge has a partnership with the top multinational pharmaceutical companies with a track record of building brands. Starting from 2010, we went through different partnerships with different global and multinational pharmaceutical companies. Starting from 2010 until 2021, went through a journey of partnerships with reputable pharmaceutical companies and medical devices companies and diagnostics as well, with Genomic Health in 2010, one of the companies that we are partnering for, with UCB Pharmaceuticals in 2012, Eisai Pharmaceuticals, Illumina, Allergan, Veracyte, Sanovion, Intercept, USA, and SERP Pharmaceuticals, which we are partnering with for our product that is concerned with the local application of antibiotics that we will go through today, Guardant Health, Amaret, Cameras, and BeGene, and the journey continues. Today's symposium is covering the topic, the application of local antibiotics in the prevention of surgical site infection, of course, in cardiothoracic surgeries, and it will probably will be a 1-hour symposium. We are honored with our faculty speakers, Professor Abdullah Shahab and Dr. Hussein Shafai. Please allow me to introduce our chairperson, Professor Abdullah Shahab. He's the Professor of Cardiovascular Medicine, and he's the Editor-in-Chief, New Emirates Medical Journal. Dr. Abdullah, with almost 25 years of experience in internal medicine, cardiology, and interventional cardiology, and medical education, and awards from the UAEU for Best Service, Best Teaching, and Best Clinical Research. The professional affiliations, Professor Abdullah is the former president of the Emirates Society of Cardiology, and is currently the General Secretary of the Emirates Cardiac Society and Vice President of Gulf Intervention Society. Professor Abdullah is a fellow of Royal College of Physicians in the UK, American College of Physicians, European Society of Cardiology, American College of Cardiology, American Society of Cardiac Intervention, and American Heart Association. Professor Abdullah's areas of interest are heart failure, coronary artery diseases, dyslipidemia, hypertension, arrhythmia, cardiac intervention, cardiac imaging, screening for cardiac diseases in sport players, and cardiovascular diseases in pregnancy. As I mentioned, Professor Abdullah is Chief Editor in New Emirates Medical Journal, and also service as editor in many other regional and international journals. And Professor Abdullah published 156 papers in Medline. Professor Abdullah, we are really honored to have you chairing this session. Thank you so much for being here, and the floor is yours.
Thank you very much, Ahmed, for this opportunity. I'd like to thank the Newbridge Pharmaceutical Company for this meeting. And let me go to my slides. share with you 1 second. Similar. Right, okay, this is the dissimilar we have to say before we start. So the meeting is organized and sponsored by Newbridge Pharmaceutical. So the views which expressed today through the 2 lectures and the discussions actually to do with the speakers, nothing to do with the pharmaceutical company. So the important notes also to feel free, please. We want you to be interactive as much as possible. The whole idea of tonight is not one-way communication, is to get your input, your comments, so we can discuss them, and feel free, anything you can ask. At the end of the webinar, you will be kindly requested to complete evaluation. Again, this is the way we learn. This is what your feedback is highly taken. So the objectives, so we know what to fulfill through this coming few minutes, discuss recent updates in prevention of external wound infection and cardiac surgery, highlight on the role of using collagen gentamicin sponge in cardiothoracic surgery. And our speaker, of course, no need introduction, but let me just give you an overview. As saying, Shafi, as you heard, is a lead cardiac surgeon, clinical lead north of Scotland Cardiac Services, University Hospital of Aberdeen, Scotland, UK. Is originally from Egypt, but it's completed his higher education scholarship in advanced students sponsored by the both Egyptian and German government. He graduated in the School of Medicine 1979, very young, still doctor, and surgery and specialized in cardiac thoracic surgery. He obtained various degrees, including, which is, or you can see the title there. He worked and obtained his training in Cairo, Glasgow, Blackpool, London, Liverpool, Saudi Arabia. So great experience everywhere. And is a current post as a consultant cardiothoracic surgeon at the University Hospital Aberdeen, Scotland. He got various experience in different type of cardiac surgery, aortic surgery, surgical treatment of arrhythmias, and he's also worked as in many committees and in the UK. So now we'd like to go to first topic of the program tonight, and with Dr. Shafi'i, and I'll stop my sharing here. So Dr. Shafi'i, please share your first lecture.
Thank you very much, Dr. Abdullah, for this kind introduction. I'm privileged today to be with you sharing this one. I hope that we will be able to cover as much as possible of the aspects of external wound infection. I appreciate that not all the audience are trying to adapt the presentation to suit everyone. And obviously, action and your questions are very much welcome. This is my disclosures. So we will go through the slides as quickly as practical so that we can add the actions. Speaking about sternal wound infection, today we are focusing on the deep sternal wound infection, which really quite a serious complication. The incidence for this complication is reported very widely, and we can talk from 0.5% to 12%. I think 5% is a reasonable estimate. So if you get 1 in every 20 cases after cardiac surgery of this serious complication, that is probably the range you expect. The causative organisms, usually Staph aureus, Staph epidermidis comes to that, but it is not unusual that you have many organisms causing the infection. It can be potentially fatal. Some people do die from this complication. That's why it is serious. The mortality reported, and some serious, is up to 50%. I think this is a little bit, maybe too much, but it is seriously potentially fatal. In 1 year, you're talking about maybe 10% versus 2% for uncomplicated surgery. So it is quite a serious and costly complication. Hospitalization, you expect so many days longer than you would expect if the surgery is uncomplicated. Reoperations can be many. And of course, you have to remember the psychological effect on the patients, relatives, and staff. People think, oh, it's a failure. People have this feeling of failure when you have this complication. The risk factors for these complications are numerous, but I would mention diabetes, as with any infection, extreme of weights, whether it is too obese or cachectic, advanced age, nicotine usage, and COPD, patients staying on the ventilators for long times, impaired immunity, nutrition, cytotoxic drugs. We usually stop drugs like methotrexate 2-3 weeks before because they do cause immunosuppression. Antiplatelet drugs here cause, we link them to the cause of bleeding, and bleeding later predisposes to infection. But most importantly for the surgeon to remember is that the poor surgical technique and the hypoperfusion, the tissue damage, contamination, use of two mammary arteries, especially in diabetics, have been associated with higher incidence of infection. Long bypass time in which there is hypoperfusion, deep hypothermia are all potential risk factors. Taking the patient back to theater once or twice also exposes them to sternal wound infection, and in addition, blood transfusion, transplants using ventricular assist devices, all of these are increased. Sometimes you get infection, even if it is deep, just involving a small part of the sternum, and you give antibiotics for a week or two, and the patient goes home. It is not of as big concern as these wounds that, they never heal. They just keep coming to you with different presentations, and they stay in hospital for so long that gets everybody depressed, from the patients to the nurse to the doctor. Now, we move to prevention of this complication. This is maybe relevant to our medical colleagues. This is the part of adjustment before the operation. So obviously, if you get good glycemic control, weight if that is possible, or improving nutrition, try to stop smoking for people. Optimizing heart failure is very important. And as I said, management of medication. We would stop anticoagulants, antiplatelets, because they cause bleeding. Of course, we have to balance that against the benefit of having them continuing. Immunosuppressive drugs, as I said, methotrexate and similar, maybe should stop 2-3 weeks before the surgery whenever possible. We have seen that, nasal swabs, this is a routine for every cardiac surgical patients all over the world, that you take the nasal swabs, and if the Staph aureus carriers, they take miopericin for 3-4 days. Treat any infection that we don't usually take patients to theater if they have ongoing infection, unless it is an emergency case, like if they have chest infection or UTI, and obviously showering with antiseptic soap the night before the operation, or even on the morning of the operation. This is relevant to the surgeons, this part. We use clipping now, we stopped shaving. I think this is, everybody does that now all over the world, because shaving can cause wound themselves, and which can be entry of bacteria. Skin preparation doesn't matter which agent you use, whether it's betadine or chlorhexidine. I think it doesn't make any difference. Studies have shown no difference. The general hygiene measure in theater are very important, and decreasing theater traffics and people walking in with a sandwich in theater, etc. All these things matter. Now, for the surgeon, the tissue handling is very important. Excessive use of diathermy, burning the periosteum. For the surgeons, you remember that the periosteum is the layer which gives you the healing of the bone. So if you burn the whole thing, indiscriminately without any consideration, just buzz the bleeding points. If you buzz it all, you kill the whole periosteum, which causes the bleeding. Hemostasis in entry is very important, and try to avoid using bone wax. Bone wax cannot be absorbed. It remains in the bone. It causes infection. So, people always blame the person who closed the chest. It's actually the person who opened the chest is the one whom to be asked about the development of this complication. So as we mentioned, try to achieve as good as possible tissue perfusion, oxygenation, try to avoid unnecessary hypothermia. When you are doing cabbage, for example, you try to separate the field between the leg, which is potentially much more dirty than the chest. So try to not to mix the use of instruments or change your gloves when you move between the two sides, etc. We're going to talk about negative pressure wound therapy. It's a very good thing. In prophylaxis, you may argue, but I think in treatment, it is a very useful thing. And we're going to talk about that in due course. And then the topic of the day today, prophylactic antibiotics, which whether systemic or local. These are the chest huggers or the support prophylaxis that you get so many types and various shapes and of it, commercial ones and homemade ones. But the bottom line here I would like to mention is that remember the patient, ask the patient if he's comfortable with them. Some people who are using them routinely actually suffocate the patient and make him feel very uncomfortable, unable to cough, and probably that disposes. So I think it's very important how the patient is tolerating them, whether he is liking them, before you actually just blanket using them. For ladies with big breasts, they pull on the wound, and I think it is important to provide them with a bra to decrease the tension on the wound. So, antibiotic prophylaxis in cardiac surgery. The systemic prophylaxis is a must in cardiac surgery. The studies which were done without giving systemic antibiotic prophylaxis in cardiac surgery were aborted because of the very high incidence of infection. Most of these studies were stopped halfway because so there is class 1 recommendation, level of evidence A, that you should give antibiotics. Most people use cephalosporins or a combination for maybe at the moment 24, 48 hours. This is a routine everywhere, and I don't think anybody should do cardiac surgery without applying them. The less concrete evidence is with local or topical antibiotics. Overall, I think the body of evidence is in favor of using them. We're going to talk about that. There is a study by Kovalevsky from the 2015 showed that the use of the gentamicin impregnated sponges or collagen sponges decreased infection by 40%. I have also another paper which contradicts that from Bennett and Guerrero, which was done in the US prior to that. But I will explain to you because I contributed actually with the workers at the time of using the gentamicin or impregnated collagen, and I think there was mistake in using the product at that moment. So I have been using this product for nearly 15 years, since 2005, and I have probably used, I would think, several thousand. So I asked myself, is it useful? Is it not useful? Is it harmful? Have I answered fully the questions? Not, but I have a good idea of some of the statements I'm going to be making. So expanded my use of this product because I found it at least harmless. If not useful, it is definitely not harmful. We initially started using 2 strips in the sternum, but now, as many others, we use 1. It saves money in one way, and it also probably does the job. In 1 year, I did about 150 cases. I was routinely using the collagen gentamicin sponge in every case. in the sternum, and I had no serious infection that year. The following years, I said, okay, from that April, we have the financial year in Britain is from April to April. So in April, I decided, okay, I'm not going to use any collagen, any gentamicin collagen sponges this year. And I got really 3 very nasty mediastinal wound infections. They required to go back to theater several times. They stayed in hospital for months, and they had this vacuum therapy and antibiotics for weeks on weeks. And I got the plastic surgeons involved. So I decided since then that using collagen gentamicin sponge in all my cases routinely. I'm not doing this out of vacuum. I think I'm backed with good amount of evidence regarding the use of local antibiotic in sternal wound before closure. So this is the NICE guidelines. This is a very respected body in the United Kingdom, and we always refer to their guidelines in almost every aspect of medical treatment. So they have looked into the effectiveness of intraoperative antiseptics and antibiotics locally before closure to see if they can prevent surgical site infections. So this, the question they wanted to raise is the application of these agents locally going to reduce surgical site infection. So they collected something like 2,000 papers, excluded most of them for different reasons, including the title, the bias, etc. And then that concentrated to about 130, and then they excluded about 100 of that. So they ended up with 30 good quality studies, and with that, they came to these conclusions. In general, after 2 months following cardiac surgery, they found that it is in favor of using the gentamicin collagen sponge before closure, and that applies to superficial wound infection and also deep surgical site infection. So a very respected opinion that has to be considered when you are making your decisions. So the recent data, as you can see, that it is in favor of using the surgical gentamicin collagen implant is effective and recommended to be used. Another body that many of the surgeons will be very familiar and maybe members of this society, which is the European Society of Cardiothoracic Surgery. Now, this is their guidelines. Again, they recommended that for Staph aureus carriers, they should have meuropyroxine for twice daily for 3-4 days. But they also here, I don't know if you can see that they have also showed that there is a significant reduction in sternal wound infection after implantation of collagen gentamicin sponge. So that's another good evidence from a very respected body. Also, another one here, World Union of Wound Healing Societies. This is a group of societies collated together to look at how to improve wound healing. It's such an important topic. So they useful to use gentamicin impregnated collagen sponges, and that would decrease surgical site infection in the chest. How to use this collagen gentamicin sponges, which is also called Collatamp commercially. We used 2 pieces initially for the sternum. We now use 1 piece, but it is also possible to use 2. There's nothing really firm about that. You can use it dry. It sticks to the fingers and it breaks off easily. So I think that's where it comes the wet application, and you just apply. I'm going to talk about that very in due course, because it is very important actually that if you're going to apply saline to the sponges, that you are very careful of how to do that. Um, the sternal edges can be wrapped. It can be put between the two sterna. It can be in front of the sternum if you wish. But there is no rules. We put it between the two sternal edges, usually just before tightening the wires. I will show you. It doesn't matter how many wires or what the way you put your wires in. It really doesn't matter. You just use it the way you think. Now, this collagen gentamicin sponges and the local application of antibiotics in wounds is not only important in external wounds, but we expanded it. We use it in endocarditis, in leg wounds. I'll show you some pictures. We use it in root abscess. We use it whenever there's a foreign material like an aortic graft. We use it in minimally invasive surgery. We use it even in thoracotomy after lung surgery. And when you pack the chest and leave the chest open, they are very useful to have actually in this situation. For our cardiology colleagues, I don't know how many cardiologists are attending today, but obviously using the pacemaker and putting gentamicin sponge in wounds around the pacing box can be very useful too. This is a video which I may just show you. I probably will repeat that at the end. So, but this is something that I need to warn you of. This is how it looks. It's about 20 centimeter by 5 by half a centimeter by 1 centimeter, and you can see that if I take this sponge and just wet it like that, I keep wetting it. All what I'm doing here is washing off. This is what I'm showing you here is how not to do. No, don't wash off the gentamicin just to make it nice, and just use it flexibly and put it there. It's nice hemostatic agent on the same time, so it doesn't cause any harm really to do that. I'm going to but here is, I don't know if you have seen this these types of wires. We use them. We use double wires sometimes. I find them very good for tightening the bone without really undue pressure or over. So for those surgeons who are interested, these are commercially available wires that you can just tighten, and when you stop, it stops. It just gives you the right tension on the bone without over tightening, which can be a cause of actual sternal dehiscence and problems. So I'll just see if we can go to the next. Yeah, I don't know if you can see this slide. It's very, it's very horrendous one. I guess some of you will not really know what we are looking at, but I can tell you, this is the head of the patient here. If you can see my arrow, and to the extreme right is the feet of the patient. This is what you see here is a wound of the leg wound, and you can see what a mess is there. So this is a kind of thing that you turn up when you're taking the internal mammary artery, and you see your colleagues that the legs are, of course, some in a diabetic fatty lady, messy wound like that. Putting a couple of pieces of Collagen in this wound, I think, is not a bad call. We sometimes have to leave the chest open for a day, occasionally two, when there is so much bleeding, usually, or the heart, you cannot, the heart is swollen and you cannot close the chest. So in these cases, you can see how it's potentially dirty situation, and it's putting some Collagen in the wound here, 2 pieces or something, before you put your packs can be very helpful. I volunteer to put some of this Collagen in root abscess when there is pus in the heart. But here is very important, and I'm repeating, it's very important that this product should not be used intracavitary. You should not put it in the cavity, whether it's a heart or great vessels. You have to make sure that if you put piece, you have to close on it by the stitches that you're going to fix the valve, for example. So it is important that if you use a small piece in the abscess, make sure it is not exposed intracavitary, because it's, of course, it can embolize and cause problems. The gentamicin very quickly this is a root abscess that you see after aortic valve. I don't know if but you can see that here the situation is bad, and you don't want this abscess to recur and loosen the valve and cause problems. So putting a small piece where this probe is and then closing with the valve stitches can be very useful. Again, when you put a big aortic graft to the valve inside, like a dental operation, having a small piece around this is not going to be a bad idea. I think it is can cause less infections, at least if it doesn't, it is not going to be harmful. This is a video I show you here that I'm going to run it a bit. Here I'm showing you, what I'm doing now. When we open this patient, she was bleeding so much from the bone marrow, because you want to see what you're doing during the surgery. But at the end, as you can see, before I'm closing the chest, I'm using a curette to remove all the bone wax from the sternum, because and then I'm going to put some pieces of collagen around the graft, and I'm going to put some in the wound before I close. So yeah, so we have here, kind of achieved some this collagen. So it is quite handy to have that. Now, of course, everyone will talk about the cost. Why should we use something? In the big scheme of things, just one deep sternal wound infection will at least triple your cost. This is well-known fact. I think there's American papers showing that this is the case. We all know that patients staying with a sternal wound infection for weeks and weeks and on antibiotics, some of them are very expensive, is going to be cost. In the bigger scheme of things, I don't know what the cost of collagen or the collagen or the gentamicin collagen sponge, but generally it will not be anything big compared to. So if you have 3 or 4 wound infections in the year, they will probably pay for all your collagen. I here want to mention something for colleagues about negative pressure wound therapy. This is a very useful modality, even for you guys, for cardiologists who are having wound infection in pacemakers or other interventions that you have, or ICDs, etc. I think it's worth it. It has saved the day. For prophylaxis, I'm not so sure. I don't think it has big impact on our practice. But for treatment, it has transformed our practice, and we take much fewer patients now for redo surgery, for rewire patient, and so remember that this is a good modality of treatment that may Hello, have I been? Are we still on, or?
Yes, Dr. Abdullah. Dr. Hussein, can you share the slides again?
Yeah, sure. I hope I'm still on. Can you hear me now?
Yes, Doctor.
Hello.
Hi, Doctor. Thank you very much for that presentation.
Aywa. Can you hear me?
Doctor, about gentamicin, kidneys.
Can you hear me?
Yes, Dr. Hussein, we can hear you.
Okay, I'll just carry on. So I just want to go through this quickly, guys, that what I'm trying to say. We, in general, you have to diagnose this as early as you can. CT scan is a gold standard. It's important that You communicate with patients, you communicate with the staff, you communicate with everybody, and you have to, that it will take a long time. Systemic antibiotics, no question. Debridement, removal of wires. Use your judgment here not to plunge into a big operation in a very sick patient. Use vac tritium if you require. And involve your plastic surgery colleagues earlier on. This is very important because really plastic surgeons do things that we cannot do. This is a medical case. Hello? Hello, can you hear me?
Yes, we can hear you.
Yes, we can hear you, Doctor. Yes.
Yeah. So this is a medical case of mediastinite, and I advise you not to open the chest if you can in a case like this, but the presence of vacuoles of air, collections, this is a hallmark of mediastinite. Now, for patients who had surgery, you can see nothing. And with these kinds of them will fail and fail and fail. And this is where you get your plastic surgical colleagues to make pectoral flaps and to take over and omental flaps. So sometimes we don't need to do any other operation. Just use back breathing just before we can use that. So as I said, if you just try to be patient, you may get away with it without, taking the patient to a surgery which may kill them. Plastic surgeons are very useful, so involve them earlier on, let them see the patient, etc. This is a patient that stayed for nearly 6 months and got cured, thanks to my colleagues in plastic surgery. You all had suffered from COVID. We all kind of suffer from the, I don't think anybody of us has not felt that COVID had bad impact on his life or her life. I came across this paper which mentioned something good about COVID, that these words in extra strict regulation theater, there is a drop in external wound infections. So everything was sad about COVID for them. I think I just want to tell you the take-home messages. Don't burn the periosteum. Don't use bone wax. Systemic antibiotics is a must. Local antibiotics, good evidence to use them, patients, and communicate well with people and the patients and the relatives and prepare them. Don't consider it as a failure because that's depressing. Get your plastic surgeons to lead involved and use negative pressure wound therapy as much as you can to avoid unnecessary surgery. Thank you very much. This is my presentation, and I will stop sharing and give the microphone to Dr. Abdullah.
Well, thank you very much, Dr. Shafi'i. I'm sorry for maybe some interruption of the internet happening. So my voice clear?
Yes.
Right. Thank you very much for this. I think this is very important to all of us to know about what's happening, how to prevent the sternotomy, infection, and it's fatal. And you showed us, up to 47 people, percentage mortality, and easy steps to take to prevent this happening. In our region, doctor, is diabetes, obesity, smoking, atherosclerosis is very common. These are the risk factors you mentioned. How we can control these to prevent this happening. We have a question here from a colleague asking, gentamicin is with the narrow index of therapeutic. They are worried in case, that affect the kidney. So what's your comment on that?
We will come in the next part. I think the next presentation will address these questions in full. It is for the kidney, but the systemic level of the gentamicin is very, very low. It does not reach anything near toxic levels. So I measure myself gentamicin levels in patients. I use maybe 4 pieces of Collagen. I know the manufacturer says maximum is 3 pieces, but we used 4 sometimes, and we didn't even detect gentamicin level. It was very low, 1 milligram per 100 ml. So it is really not going to affect systemic levels at all. We're going to mention that in the next presentation.
Okay, I think maybe this is the second question as well, maybe related to that. Will we remove, when will remove the gentamicin sponge before closure? I mean, will you remove it, the sponge? Asking
you see, this is the beauty, this is the beauty of it. The collagen gets absorbed by the body. So you don't need to worry about it. In fact, if once you open the chest, say 7 days later, you don't see any sponges. It's all gone.
Okay, so that's
the collagen is absorbed by the body. You know, the macrophages that eat the collagen. So you just left with the gentamicin to work.
Yeah, because the third question was about how long it takes. That's good. You answered everything.
Yeah, a week or 2, I think it becomes very rudimentary.
Excellent. So I don't think we have any more questions. Can we go to the second talk, which is collagen gentamicin sponge, the usage and role in cardiothoracic surgery?
Yeah. Yes, I'm going just to put some information here. One second. I'm trying just to apologies for the delay. I hope you still hear me.
Yes, yes, yes.
Yeah. So the usage of this products in cardiothoracic surgery, in fact, in anything, no. But this is just information about the product, which is called Collagen, which is commercially called Collagen from a company called SERB. This is a composition of this sponge. Collagen is 2.8 milligram per square centimeter, and gentamicin equivalent to 1.3. So you get these sponges in these shapes. This is 5 by 20 by 0.5. This is the same size, but a different shape to suit different types of wounds. And this is one which is half the size, say for a pacing box wound or something like that. This is the one which we usually use, 20 by 5 centimeter average sternum. So this is how it works, guys. This is the collagen and the gentamicin in it. The collagen will going to be absorbed and eaten by the macrophages, while your gentamicin will be absorbed locally into the tissue. It has a hemostatic function, definitely, and it also may promote wound healing, maybe some excitement for the healing tissues. But the gentamicin reaches locally quite a good concentration, like 2,000 small concentration. I myself personally did never detect more than maybe 0.5 milligram per liter. So this is the question that was asked about the kidneys. It never reaches anything like a concentration to harm the kidneys or to cause any renal dysfunction. This diagram will show you also the local concentration versus the systemic concentration. And the gentamicin can be available for the first 2-3 days in a concentration for the kidneys, and it's not even near it. So we have it here as 4 milligram per liter is the minimum inhibitory concentration, the one you want to achieve, and this is achieved in your local wound. The systemic circulation, you don't have the problem. So this is just some information. You can cut it. You can use up to 3. The manufacturer recommends up to 3 of the big implants. No more than that. I used more without having problems, but the manufacturer recommends that not to use more than 3. The size of the implant is the idea is not to put more than 9 milligram of gentamicin sulfate in your wound. You can put the gentamicin and press of it for 3-4 minutes, but you don't have to do that in cardiac surgery. Really, you just put it in. If you want to use this for hemostasis, this is when you really the gloves and instrument may be weighted, but as I said, if you weight it too much, you just wash off the gentamicin that you paid the money for. So don't overdo it with washing or weighting. This is the video that I showed you before for people who maybe weren't concentrating or weren't looking. But as I say, don't wash the gentamicin off the sponge by putting it too much in water, because that's one of the reasons why a study showing no benefit of this failed. Just put one piece, and it is very fitting to the sternal size. You put it dry, and then you tighten your wires over it, and then you close the wound in the normal way. It gives some hemostasis. It's not going to stop, bleeding from the aorta or anything like that, but it certainly can be very useful. So so this is, I think, the end of the presentation. I'm very happy to take any questions, and I will stop sharing the screen and move the microphone to Dr. Abdullah.
Thank you, Dr. Shafi. Again, I think what was a question we missed from the first topic. He says, as you mentioned, that it should not be kept in the cavity like thoracic cavity. Does this hold true for peritoneal cavity as well?
No, I think I'm sorry. I didn't mean that it should not be left in the cavity. You can leave it in the chest. You can leave it in the heart. Sorry, you can leave it in the chest. You can leave it in the abdomen, but not intracavitary. I meant cardiac cavity. I didn't mean cavities as in peritoneum and thorax. I meant the heart, because when you have, say, endocarditis and you have a root abscess at the bottom of the aorta, and burrowing into you don't want to put a piece inside the heart. That's what I meant. I'm sorry if that was not made clear, but I meant the cavity of the heart, no cavity like. But if you leave it in the chest, or if you leave it in the peritoneum, it will be absorbed. It will not cause any harm. But you don't want to put it intracavitary in the heart, because that can embolize this and cause embolization.
Yeah, Dr. Shafi, with the COVID-19 pandemic, and the amount of precaution we take, and we know the external, internal causes for the infection anywhere, especially the sternal. So what's been your experience during the pandemic? Maybe you want to share with us.
I think cardiac surgeons have suffered during the pandemic because, for example, in the beginning, we had very strict regulations of, when you intubate the patients, you have to wait 20 minutes. And when you extubate the patient, you have 20 minutes. And when you open the chest and use the saw, was, what they call it, aerosol generating procedure. These aerosol generating procedures were a headache because they meant 20 minutes, 25 minutes for everything. So cardiac surgery suffered from that. But we had to really embrace what was, guidelines. As you know, the knowledge about the COVID is very scarce, put it this way. But as I said, I showed a paper, I think from Asia, showing that the people, because of this so much strict traffic in theater, not many people going in, all these precautions that have been excessive, they found that wound infection have decreased. So it is a difficult balance. But as a whole, I think COVID has occupied the critical care beds. It had a negative impact, and many patients, for example, in the United Kingdom now, unfortunately, had neglected disease, have suffered complications, even death while waiting for their cardiac surgery. So I think now people are more realizing that COVID is not the only problem. There are other problems like cancer, like cardiac disease that has to be addressed along with COVID. So I think there's a shift in the opinion now, and I think people have to accept that COVID is not going to go away.
Yeah. So the incidence of the sternal infection you mentioned, which is very wide range, from 0.5 to 12%, you mentioned. So what was the reason for that? That's.
I think it depends. Yeah. It depends on the reporting, Dr. Abdullah, really. These are the different papers that reported incidences, so as I said, from 0.5 to 0.5 means 1 every 200, and 12%, so means 1 every 10. So as you mentioned, yes, it is. But this is the case, even if you look, for example, incidence of atrial fibrillation following cardiac surgery, you find people reporting 5% and people reporting 60%. So I think it depends on the institute. I don't think it reflects badly. I think if you get up to 1 in 20, that's reasonable. If you get more than that, you start to question your practice. Am I doing something wrong? If you get, say, more than, if you get, say, every 5 cases a serious wound infection, I think you have to stop and say, well, I'm doing maybe something not right here. So yeah.
So observational studies, randomized clinical trials showed us the efficacy, safety, and of this approach. Does that apply to if you're speaking about the bypass? If we do both Lima and Rima, is it the same or
I think I don't think they made a study specifically with Lima, but it is well known that if you use both Limas in diabetics, there is higher incidence of wound infection, and most people would avoid, if possible, using bilateral IMAs in diabetics, especially if it's insulin dependent. It may be, you may get away. So, to devascularize the chest wall, the anterior chest wall, and then, in a diabetic may not be a very clever idea. So I think it is, one should be careful when he applies bilateral Lima. I personally use bilateral Lima only when I need to.
Yeah, this approach been there for a long time. I mean, what's the uptake of this with the surgeon community? Is it what we can say? Did you hear my question, or was it? Did you hear my question? I'm not sure if the. Doctor, did you hear my question?
Sorry, would you kindly repeat that again? I think I lost that one.
Yeah, I'm saying so this approach of external prevention using gentamicin sponge been there for some time, no? I mean, it's been.
Yes.
What's been the uptake by the communities, surgical community, and others of this? Is it improving? Is it? What if it's not improving? What's the reason?
I think it is improving. I think more and more surgeons think of using it because it is harmful. But unfortunately, there are many limitations because of funding, cost, etc. So people, but I think people, when they can afford it, they use it.
Right. Okay. So far, we don't get any more questions. Let me summarize of the meeting of tonight. I think is really, for me, I've learned a lot with experts like Dr. Shafi'i shared with us his experience. So during our meeting today, we were able to discuss and highlight the following: risk factors for external wound infection. And I say this very common. We discussed this, how common diabetic, obesity, cardiovascular diseases, smoking, and so on, and how we can together, work on this and improve this. And then the recent updates in prevention of external wound infection in cardiac surgery, highly beautifully with the example showed by our Dr. Shafi'i. And then, of course, showed us, we have approach, we have something really established through observation, randomized clinical trial, how the collagen gentamicin sponge and calcium surgery, the role of that prevention of the infection, which could be very fatal, to the extent of, almost, reaching 47%. So I think, this is very valuable, very practical education. And I hope you guys learn from this education of two beautiful lectures by Dr. Shafi'i. And at the end, I'd like to really thank all of you for this opportunity and your bridge to bring this highly educational activity together with your questions or your comments. So please don't forget to write your evaluation of this meeting. We learn, we will improve it next time better than this. Inshallah, we'll improve the internet as well as time goes. So Dr. Shafi'i, thank you very much for your high valuable contribution. Thanks also Newbridge for this opportunity, making this educational, and thank ICOM for a beautiful organization. So thank you very much, and see you next time.
Thank you very much, Dr. Abdul. Thank you.
Assalamu alaikum.
Bye now.